I want to recognize the leadership that is here, led by Professor Pamela Kimeto and lecturers present, partners who are partnering with Kabarak University in this event, and all the participants. I greet you all in Jesus' name. Good morning, and praise the Lord. I want to share briefly from two passages of Scripture. The first one is Ephesians chapter 2, verse 10. Ephesians chapter 2, verse 10. And then Colossians chapter 3, verse 23. Ephesians chapter 2, verse 10, the Bible says, "For we are God's handiwork, created in Christ Jesus to do good works, which God prepared in advance for us to do." Colossians 3:23, the Bible says, "Whatever you do, work at it with all your heart, as working for the Lord, not for human masters." I want to share briefly on the subject, service to God and humanity. Service to God and humanity. God in His own grace has called on each one of us and given them an opportunity of service in this world. In His quest of expanding His kingdom through us, He has gifted us with abilities, talents, and spiritual gifts to better our world. When we talk about service, it is where we are ready to work for. We are ready to perform duties. We are ready to assist. We are ready to be used of to better others in God's kingdom. So as we rise up to do something to better our world, we do so through the abilities that God has given us, the talents that God has given us, and the spiritual gifts that God has given us. So my question this morning is, what are some of the pillars of a powerful servant? Pillars of a powerful servant. Number one is sacrifice. Sacrifice. Someone has said, you make a living by what we get, but we make a life by what we give. So life is not about duration, but about donation. What is it that you can do so that you can better our world? So we are called by God to respond to people's needs. And as we do that, we sow seeds of prosperity in lives of others. So we must lose something. You must give up to go up. The higher the level of responsibility that God gives us, He wants each one of us to attain a greater sacrifice to better our world. So even as you gather in such a great symposium, thinking and finding solutions of how you can help people in this issue of antimicrobial resistance issue, it has to do with sacrifice, where you set aside some time, set aside some resources so that you can help our world. Secondly is enthusiasm. Enthusiasm has to do with energy. It has to do with purpose, where you want to see that the aims, the objectives, the mission, vision that you have can be brought into accomplishment. So it doesn't need you to be a faint-hearted person, slow, lazy, but you must rise up and be enthusiastic enough to trust that which you want to do and change our world. Number three is respect. This is a joint venture where partners come about and we think and try as much as possible to come up with a solution that is amicable for us all. So, sometimes we may differ in our thinking. Sometimes we may differ in our solutions venture. But the bottom line is we need to respect one another, respect the positions that we hold, and try as much as possible to come up with something that can help us all. You really haven't submitted until you disagree. And sometimes in our disagreements, we must make sure that we don't win the argument and lose the mission, vision, and the thought that we have. We can lack respect if we have an independent spirit, if we have a heart that fails to admit mistakes, if we have a spirit that is unteachable, if we have a rebellious attitude, and even failure to accept others. So when we come and think together, and especially perform acts in partnership, we need to respect full pillar of a servant. The fourth one is value. Value. We need to be great thinkers who come up with values that can help us. You can't talk about to ask myself as I offer myself to this symposium is, what value will I add? What am I bringing to the table? What is that something extra that I can better the AMR? So good thinking produces good products by the end of the day. And we need to look carefully for where and how we can add value in our service to God and even service to humanity. Let us not overlook the things beneath that can help us to do better as we secure our present and even our future. Number 5 is integrity. We live in a society where integrity has been thrown out of the window. This is the quality of being honest. And it ties much with the aspect of sacrifice that I mentioned earlier. Say that even in such ventures, it is not about what am I getting. It is not about what is in for me. Any kickbacks? No. It is about honesty. It is about faithfulness. How can I be faithful enough, even with the little resources that I have, in my quest to change people's lives? So, integrity is actually the bedrock of service. This service to God and even to humanity. So if we are to serve, our character must stand out. Say that no one can point fingers on us, such that no one can have questions as far as our lives is concerned. Like someone said, and I quote, when money is lost, nothing is lost. When health is lost, something is lost. But when the character is lost, everything is lost. Lastly is commitment. Every great endeavor has a price tag. The greater the job, the higher the price. And the greatest price tag of all time is commitment. In your busy schedules, you find time to come and discuss and have a symposium like this that shows some level of commitment, which is required as far as service is concerned. So commitment will not only get you started, but it will help you keep going. It is actually your motivation speedometer. Commitment will help you to accomplish much if you stay on course, despite the challenges and even discouragements that may come on your way. So may God help each one of us and even help us as we engage in this. Let us pray. Our Father and our God, we want to thank you this morning for the gift of life and good health that you have given us. Thank you for the opportunity to gather together, challenge our minds, and find solutions for that can help alleviate the problems of humanity. And we thank you even for today as we think of the issues that are affecting us. We pray that you may help us, O Lord, to offer good service to you and even to others. May these pillars that we have gone through help us to do better as we use our abilities, our talents, and spiritual gifts that you have given us. Be with us and lead us well, for we pray with thanksgiving in Jesus' name. Amen. Thank you very much, and may God bless you.
Thank you, Reverend Kitoni, for that very insightful and relevant biblical thought. Ladies and gentlemen, we at Kabarak University pride ourselves of 7 schools which teach in biblical perspectives to prepare global leaders. And at this point, we want to request the School of Music once again to come on stage and do one piece as we prepare for ourselves. Just for us to remember that the theme for this symposium is Act Now, Protect the Present, Secure Our Future. And the people that are going to present here are going to be part of securing our future. Welcome to on stage.
The School of Music and Media Brass and Woodwind Ensemble performs a rendition which is Praise. Yes, enjoy.
Let's give them a round of applause. Brilliant work. clearly this is talent that is at a global level. At this point, ladies and gentlemen, I want to invite each one of you in a special way. Karibuni sana to Kabarak University. And we also acknowledge the many members of public and in the medical field that are online. We want to start off the session today, and with a lot of humility, I want to invite Professor Pamela Kimeto, who is going to have opening remarks, and then she will invite the County Government of Nakuru representative to also give her opening remarks. Professor Kimeto, please. Let's give a round of applause.
Good morning. Good morning. It's good to see all of you here. We may not look very many, but one thing I know is when we are gathered together, something is going to work. Before I go into my speech, I want to recognize all the people that are here. We have the people from the national government. Where are you? If you're from the national government, please rise. Thank you for coming today. Then we have representatives from the County Government of Nakuru. Thank you for coming. Then we have people from Egerton University. Please rise. Thank you. We have representatives from our community, just the surrounding community. Please rise. Thank you for coming. We have the Kabarak fraternity. Thank you. We are very few because we have exams, so almost everyone is in the exam room, and those that are not in exams have managed to come here. And so before I give my speech, I want to invite Dr. 𝐒𝐲𝐬, who is the Dean School of Pharmacy, to greet you. And this is his area of interest. His study has been on 𝐒𝐲𝐬𝐴 and the use of antibiotics and the spread in, the resistance that we are seeing in children under 5. So he's at home today discussing what misuse of antibiotics can do to our healthcare system. I'll give him a few minutes and then I'll give my speech. Dr. 𝐒𝐲𝐬.
Thank you, Prof. All protocols observed. Good morning. Yeah, so this is something nice in terms of thinking through on our next steps. We've been thinking of other pandemics coming, but the pandemic that is coming is on resistance. How we approach it really matters a lot. And so if this is tackled, we are able to save the future. This is left out. This is what is going to wipe us. So we need to start with the baby steps, and I'm glad of this platform that is being provided. Thank you, Dr. Tonui, Dr. Lydia, for steering this journey. The baby steps, we are hoping in the near future will bear fruit, where we're able to conserve, have a One Health approach, whereby from the community perspective, you can support us. From the medical practice, we can really enhance. I wish we had the Pharmacy and Poisons Board, which is the regulator, to come in to also help in regulations, because part of it is the lapse from the regulatory aspect. the content of these molecules in milk are quite high, more above the normally the parts that are required. So we thank the team that has started. This is my area, as Prof. Palmer said, and we are hoping we can move this to the next level. And the teaming up from the county, we really appreciate your initiative. And as Kabarak, thank you 𝐿𝐴𝐷𝑚 for joining. So if we can create one consortium so that we can be able to manage these antimicrobial resistance. The basic molecules like amoxicillin are no longer working. And those are the first line. And so it's really, you really need to understand that now, beyond the 5th generation, where are we going to? We have nothing. So thank you so much. Be blessed. I hope we'll be able to learn more. Thank you, Pam.
Thank you, Dr. 𝐿𝐴𝐷𝑚. Ladies and gentlemen, distinguished guests, I'm here to give a speech on behalf of our management who are not able to attend this meeting today, but they are with us in spirit because of a lot of competing activities that are happening. As you're aware or may not be aware, we have our graduation next week on Friday. And so before the graduation, there's normally a lot of activities going on, and that is why they are not here with us, but they send their greetings. Representatives from the County Government of Nakuru, the federal government, we are glad that you came here to join us today, together with our community, as well as us from our neighbor institution, Egerton University. It is my great pleasure to warmly welcome all of you to Kabarak University for this important Joint Antimicrobial Resistance One Health Symposium. Today marks a significant milestone as we come together as academia, county leadership, health professionals, veterinarians, environmental experts, agricultural officers, students, and community representatives to confront one of the most urgent health threats to our time. A long time ago, when you go to a class where antibiotics are taught, we were told that when we discovered the first antibiotic, it was a miracle drug. It healed a lot of conditions then. If you've heard about the 𝘚𝑗𝐺 study, that is the syphilis, we know the role that these antibiotics played. But over time, we have accessed antibiotics so much to the point that what was meant to be very good, what was meant to be a magic drug, has turned out not to be so good at all. And if you notice, lately when we have our children have the upper respiratory tract infections, we no longer go for our first line medications. Why? Because they have become resistant. And when we give it to the children, 2 weeks later they are sick and they come back to us. So antimicrobial resistance has emerged as a silent pandemic, slowly undermining decades of medical, veterinary, and public health advances. There was a lot of work that was put into development of these antibiotics. But right now, we seem to be going back because of our practices, the way we use these antibiotics. Across the world, the misuse and overuse of antibiotics, antifungals, and antivirals in human health, animal production, and agriculture have accelerated the rise of resistant pathogens. Just yesterday, I spoke to somebody who had a wound, and I asked the person what they were doing for that wound. And guess what they told me? They were mixing an antifungal, an antibiotic, and an analgesic all together and being applied to that wound without bothering to even do a culture to know what was in that wound. So that is one example that I encountered yesterday. There could be many more. And that just proves how we are handling these antimicrobials in a not so safe way. The microorganisms that we have lately are no longer responding to the very medicine that were designed to treat them. And today, routine infections are harder to manage, treatment costs are rising, and common medical procedures that were once considered to be very safe are becoming very risky. You know, this calls for us to start thinking, what is it that we are doing when somebody comes to you and you just prescribe by the side of the road and they go into a pharmacy, and I like what Dr. Suge said, that the PPB should have been here. You go to the pharmacy and you're able to procure antibiotic, that antifungal. What are we doing to our generation? Closer home here in Nakuru and the wider Kenya health system continues to witness rising cases of drug-resistant infections. These infections affect families, livestock, food system, and our environment. The reason why we are here together today from the different spheres, the community, the national government, the county, the practitioners, because we are all using these medications, and to come up with a solution to start decreasing the resistance that we are facing. This is because antimicrobial what next? What are we going to do? And so we need to come up with a plan that is going to solve this problem. And so it is for this reason today that the One Health approach, which recognizes the interconnectedness between human, animal, and environmental health, has come together to discuss this very important topic. We can no longer address antimicrobial resistance in silos. You cannot have the health discussing it by themselves, those taking care of animals discussing it by themselves, and those that are in the communities taking care of ourselves. Our system has been in such a way that if you want an antibiotic, any antimicrobial, somehow you'll get it. And we've not been very good users. We've not been good stewards of what has been given to us. And so coming together as One Health approach is going to help us form and come up with solutions that are all agreeable by all of us, so that when we go back to our jurisdictions, we can now start thinking and mapping out ways to reduce this problem. So what happens in hospitals connect to what happens in our farms, what flows into our rivers, and the everyday health practices in our communities. We give antibiotics to our animals, and we milk them the same day. We may not drink that milk, but we choose to sell it. And the next person who drinks that milk is drinking what? Milk full of antibiotics. We give antibiotics to our chicken, and they lay eggs. And the same day those eggs are laid, we give them. We give antibiotics to our animals. Sometimes they are unwell. They may not survive. And somehow we end up eating that meat. When we think about the hospitals, how good are we? How prudent are we in prescribing the antimicrobials? How do we use the knowledge that we have? Do we use it professionally? Sometimes that is not the case, and that is why you find people lined up in pharmacies buying antimicrobials, and these antimicrobials are given to them. And then within no time, whatever used to work for them on a lower line is no longer working for them because they've had various prescriptions from different people, and now they are becoming resistant. And so we need to have a shared responsibility and integrated surveillance so that we can address this challenge, antimicrobial resistance. I commend the County Government of Nakuru for partnering with Kabarak University in co-organizing this symposium. This collaboration is timely and necessary because our joint efforts will not only symbolize a growing recognition of AMR, but also through cross-sectoral partnership, evidence-based decision-making, and sustained investment, we can come up with good stewardship protocols and create public awareness. As a university, we are committed to supporting this agenda through research, training, innovation, and community engagement. Our faculty and staff are actively contributing to AMR surveillance through laboratory works and also laboratory strengthening, biosafety and biosecurity programs, together to build a capacity of frontline workers. We see ourselves as a key partner to the county and the national government in developing and implementing sustainable solutions. So as we gather here for today's symposium, we sit to exchange knowledge, share experiences, and identify areas where we can work together more closely. We may have been working together, but we need to work together more closely, and this can be in the diagnostics, it could be in infection prevention and control, it could be in the laboratory systems, in the veterinary medicine, agriculture, environmental monitoring, or community education. When we come together from diverse backgrounds, we come as determined to confront this challenge comprehensively. I encourage each one of you to fully engage. Let us ask ourselves difficult questions and explore practical collaborative interventions that will strengthen our counties and even at the national level AMR preparedness and response. Let this symposium mark the beginning of a county university partnerships, and I want to include the community too, because we cannot do it without the community, and a shared commitment to safeguarding the health of our people, our animals, and our environment. Thank you for coming here today, and thank you for bringing this to fore, for considering it a major problem and coming together to solve it. I also want to thank your respective sectors for being in the front line in addressing this issue and you representing them today. Well, let us take bold steps together towards a healthier and a safer future for all of us. Thank you. It is now my pleasure to invite Madam 𝐿𝐴𝐻𝐿, who is the Sub-County TB and Leprosy Coordinator, on behalf of the Sub-County TB and Leprosy Coordinator team lead, to give her speech. Karibu, Madam Esther.
Good morning, everyone. As you've heard, my name is Esther 𝐿𝐴𝐻𝐿. Today I'm standing in on behalf of our sub-county team lead, Rongai Sub-County, Department of Health, and also on behalf of our county leadership. So, welcome everyone, and I would like to let those whom we came together from the Department of Health stand up so that we can appreciate them. Kindly stand up and wave to the congregation. Department of Health, yes. Yes, so these are the people whom we came together with, and sit down. Thank you. So I'll just go straight away to give the speech on behalf of our county leadership. So this is an opening speech for the county leadership antimicrobial symposium, Nakuru County, and between Nakuru County and Kabarak University. Ladies and gentlemen, distinguished guests, representatives from Kabarak University, our development partners, colleagues in health and across the One Health spectrum, all protocols observed, good morning. It's my great honor and privilege to join you today as we officially open this important antimicrobial resistance symposium between Kabarak University and Nakuru County. Today marks not just another meeting, but a powerful convergence of knowledge, leadership, and shared responsibility in safeguarding the health of our people, our animals, and our environment. Antimicrobial resistance is one of the greatest global health threats of our time. Here in Nakuru County, we have witnessed firsthand how antimicrobial misuse, self-medication, and inadequate infection practice can undermine the gains we have made in the healthcare. When medicines fail, surgeries become riskier, infections become harder to treat, and the cost of care rises, straining families, communities, and our health system. And for this case, I'll just give an example. Like I've just told you, I coordinate TB services in Rongai sub-county, and we've also had several drug-resistant tuberculosis cases in our sub-county. And for that matter, these resistance not just come about, but they come about because of poor adherence. Someone is diagnosed of TB, initiated on treatment, and on that note, when they feel healthier, wakisikia nafuu kidogo, they just get lost to medications. And remember, they've taken those antibiotics for treating TB. So as a result, they will continue developing that resistance. The bacteria will undergo mutations, and therefore, in the end of it all, we get these cases developing resistance, and as a result, the disease or the bacteria itself we will not be able to use the normal drugs we've been using. And we have several cases which end up becoming difficult to treat and even costly to treat. Because when one develops TB resistance, we don't even have those medications around here. We have to order them from Nairobi, from KEMSA. So, and remember, TB is an infectious disease, right? So we really need to have concerted efforts from the community, giving health education around our communities so that we can be able to prevent the emergence of drug resistance, bacteria and microorganisms. So allow me to continue. So as a matter of fact, I told you when drug resistance emerges, it becomes very costly, not only to the family, but also to the community, and also to the county, and also to the national, to the country at large. So, as I told you that we end up straining our health systems at large. This is why gatherings like today's symposium are very critical. As Nakuru County, we remain fully committed to strengthening antimicrobial stewardship, enhancing surveillance of AMR and antimicrobial consumption, and promoting responsible use of antimicrobials across all sectors. We recognize that no single department, institution, or profession can win the fight alone. And that's why we are here today from all departments, from the Agriculture Department, Livestock Department, Human Health Department, and also Environmental and Community. I wish to commend the Nakuru County Antimicrobial Stewardship Interagency Committee, 𝐷𝑘𝐻𝑖𝐶, our healthcare workers, our veterinary teams, our environmental health officers, and all stakeholders represented here today. Your dedication continues to move us forward. So when we come together, our efforts become huger, and our team spirit becomes stronger, and our motivation becomes stronger. As we begin today's symposium, I encourage each one of us to engage deeply in the discussions, share our experiences together, challenge our assumptions, and forge stronger partnerships. Let's live here with actionable strategies that we can embed in our daily practices, whether in hospitals, in our farms, in our classrooms, in our laboratories, or in our communities. Together, we can build a county where antibiotics remain effective, patients receive quality care, farmers thrive, and our environment is safeguarded. Ladies and gentlemen, thank you for your commitment and your presence today. It is my honor to officially declare this Nakuru County Kabarak University Antimicrobial Symposium open. Thank you and God bless you. Asanteni sana. I just wish to extend the greetings from our sub-county team lead, who is on leave, and also our county leadership for the many engagements that they weren't able to be here today, but we've come representing all of them. Thank you and God bless you.
Thank you very much, Madam Toretich, for that very relevant and insightful speech on behalf of the county. At this moment, I want to invite Lydia Momanyi, who is one of the members coordinating AMR in the county. She will introduce herself a little bit more and the rest of the team, and then she will also invite one of our colleagues from Nairobi to give his speech. Madam Lydia, please.
Good morning, everyone. Okay, my name is Dr. Lydia Momanyi. I am the AMR focal person, Human Health, and I work in the Department of Health Services in Nakuru County. We are really delighted to be here this morning and this collaboration with Kabarak University to hold this AMR Symposium in commemoration of the World Antimicrobial Awareness Week. And the theme is Act Now, Protect Our Present, and Secure Our Future. So I am also delighted to invite our keynote speaker. It is Dr. Emmanuel Tanui. He's the National AMR Focal Point under the Kenya National Public Health Institute. Dr. Emmanuel Tanui is a specialist pharmacist working at the National Public Health Institute in Kenya. He has over 10 years of experience strengthening public health systems from a One Health perspective. As the National Antimicrobial Resistance Focal Point and Secretary to the National Antimicrobial Stewardship Technical Working Group, Dr. Emmanuel is dedicated in combating the growing threat of antimicrobial resistance. In his role, he spearheads initiatives aimed at developing and implementing comprehensive strategies to address AMR, working closely with healthcare professionals, researchers, policymakers, and other One Health stakeholders to ensure effective coordination and response. He has led the successful development and launch of the AMR National Action Plan, that is the current one, 2023 to 2027, among other key strategies. He's passionate about establishing functional health systems to support implementation of AMR policy and the National Action Plan at all levels. Dr. Emmanuel Tanui, you're welcome to make your presentation. Thank you very much.
Dr. you have the right to share, so you can proceed and share. Thank you, Dr. You can have a seat as we wait for Dr. to share his presentation. Dr. we can see your presentation. Maybe you want to unmute and proceed.
Yes, I have unmuted.
Yes, we can hear you clearly. If you can do presentation mode now. Perfect.
Is it okay now?
Very well, and you can hear very clearly. Please proceed.
All right. Thank you so much. First of all, let me thank the organizers for this opportunity to be able to share our experiences from the national level. As you heard, my name is Dr. Emmanuel Tanui. I'm the National AMR Focal Point. I think this symposium is an opportune moment for us to be able to highlight the issue of antimicrobial resistance, which is a continuing threat. And we are actually seeing increasing and alarming numbers from across the globe. So my presentation is going to focus majorly on how we can be able to work together through the One Health approach, able to implement the priorities that we have identified as a country, guided by our National Action Plan. So the outline of the presentation is just to provide a background on AMR. I know we'll be discussing and we'll be having quite a number of presentations from different stakeholders during this symposium, highlighting on the issue of AMR, so I may not spend a lot of time giving a lot of background on AMR, but focus majorly on the policy and the framework issues, the relevance of One Health coordination when tackling AMR, why this structure is important in effective implementation of our strategies. The governance and coordination structure that is in existence and reflection at the county level, the challenges and the call to action. So AMR is an urgent reality that we need to address, because from the numbers that we have seen based on the surveillance across the globe, AMR is responsible for almost 5 million deaths annually. And Sub-Saharan Africa actually bears one of the biggest burden due to our challenges in health systems, limited diagnostic capacity, poor infection control, and so forth. And some of our vulnerable populations are the ones that face the biggest risk. For example, in 2019, 1 in 5 people who died due to AMR were children under 5. So it means that we as a country need to prioritize our interventions to protect these vulnerable populations. Projections from the current data, by 2050, we'll have as many as 10 million deaths per annum, with Africa alone contributing more than 4 million deaths. When you come to our local scenario in Kenya, we face high levels of resistance for Enterobacteriales, E. coli and Klebsiella. We've seen resistance of E. coli and Klebsiella towards ceftriaxone, which we use quite a lot in our health facilities, resistance being higher than 65%. We even have instances of resistance of 85% amongst Klebsiella isolates. We are seeing rising levels of resistance in Staphylococcus aureus, which causes a lot of soft tissue infections and so forth. We are seeing increased use of watch antibiotics, for example, ceftriaxone, in our health facilities. Yet the guideline recommendation is that we first need to consider the first-line drugs which are in access. Drivers of AMR exist in both hospital and community settings, and these are some of the drivers of inappropriate use. So we need to work together. And this is not just isolated to human health. The AMR agenda is multi-sectoral, meaning that we need to consider the One Health approach that brings together the different sectors to address those interconnected drivers across the sectors. So there are different drivers of AMR which have been identified, and our One Health approach tries to address these drivers, starting from inappropriate prescribing to over-the-counter cells that are not regulated, infection prevention and control, inadequate wash leading to spread of multi-drug resistant organisms, the misuse of antibiotics in livestock, where they are used for promotion or for prevention of diseases, which with total disregard to hygiene. The challenge of diagnostics also is not left behind, where a lot of prescribers, because of inadequate diagnostics, may resort to blind treatment without following guidelines. The challenge of poor waste management is also an area that drives AMR. So we have developed different strategies in alignment with the Global Action Plan. Kenya started this journey of establishing a national action plan in 2017, which we have now reviewed. We have a current version 2 of the national action plan, which we launched in 2023. So we've been implementing this in realization so that we can be able to enforce the AMR policy, which was earlier developed. It focuses on 6 strategic issues of governance and coordination, requiring that we establish governance and coordination structures to be able to tackle AMR in a One Health approach. We are required to create awareness and understanding amongst members of the public, conduct training and education for professionals so that we can improve the knowledge and understanding on AMR. It is a belief that once people are aware about AMR, then this can lead to changes in practice. The other strategic area required for us to focus as a country is on surveillance and monitoring. We are required that we continuously monitor the trends and the patterns of resistance and antimicrobial use, antimicrobial consumption. If there are any inappropriate disposal of antimicrobials, we are supposed to highlight this for urgent mitigation and for us to be able to understand whether our interventions have an impact. The other strategic area we are required to focus on is infection prevention and control, basically to prevent the spread of antimicrobial resistant organisms in both human health, animal health, and environmental health settings, so that we limit the spread. The role of prudent use of antimicrobials has also been highlighted, so that we can be able to reduce the rate of emergence of resistance and promote access to essential medicines. The last strategic area is on research and development, which requires us to promote research on AMR so that we can be able to promote rapid diagnostic testing and also for alternative treatment where current treatment options are not available. So basically, this implementation framework requires us to work together between the human health, animal health, environment, and agriculture. Of course, that does not mean that we do not encourage sector-specific interventions. Yes, there are very many sector-specific interventions on clinical care, prescribing practices, patient safety, hospital, infection control. So when these are implemented within that sector, the animal health as well, they have their own sector-specific interventions. However, in terms of coordination, governance structures, implementation of awareness campaigns, integrated surveillance, those require that we integrate our work so that we work together. So what governance and coordination structures exist? We have, as guided by our national AMR policy, we have a One Health Interagency Committee at both national and at the county level. At the national level, which is a National Antimicrobial Stewardship Interagency Committee, comprising of representation from the Ministry of Health, Agriculture, Environment, Aquaculture, addresses policy issues, coordination issues, resource mobilization, and so forth. And this is supported by the technical working groups on each of the strategic areas of surveillance, awareness, stewardship, infection control, and monitoring and evaluation. So this is mirrored to the county level, and the county committees are responsible for developing their own work plans, One Health in nature, and ensuring that the actions are actually decentralized to all the way to the facility level. So the counties play a very big role in terms of implementing the national strategy, because what we see and we're aware is that all the work at the on AMR implementation, really the actual work happens at the ground, at the facility level, at the community level, at the farm level, the environmental level. So basically the counties are required to establish functional classics to be able to operationalize the implementation of the National Action Plan. These structures require to be given very clear terms and responsibilities with actions to be able to implement. So these classics will support the rollout of the AMR surveillance to be able to monitor the disease, the resistance patterns, how we are using our antimicrobials, ensure that we have functional antimicrobial stewardship programs beyond the county referral hospital, to include even the level 4 hospitals. The counties are required to embed AMR actions or action plans within the county health plans, the CIDPs, the annual work plans, for purposes of ensuring that we have sustainability beyond the donor-funded project setups. They are also supposed to strengthen infection control and biosafety, biosecurity, and also environmental surveillance. And this can only be possible by allocating county resources for strengthening diagnostics, capacity building in terms of training, and health systems infrastructure. So how do you translate the data? Once you're able to collect the data, whether it is infection prevention control, because we all aware that for evidence-based treatment, for us to be able to do proper surveillance, we need to have adequate capacity in terms of laboratory and other diagnostics. We have seen instances of frequent stockouts of essential supplies. Our request is that going forward, if the government equipment provision programs for the counties can include even microbiology equipment, some essential supplies. This can ensure that we have sustainability, and we have been trying to share policy briefs for the consideration of inclusion of these essential equipment and supplies for microbiology. And I'm sure counties can also pick up these rallying call for us to ensure that we have uninterrupted diagnostic services. Poor IPC in the community and healthcare settings and controlled access to antibiotics, especially in the community setup, is also one of those challenges affecting and even negating the work that we are doing. Gaps in AMR surveillance data, especially in terms of our reach. We do not have surveillance sites in marginalized areas, and this is one of the challenges that is associated with the limited funding and the inadequate AMR coordination structures. So as I end up my presentation, what is the call to action for us to the counties? One is to request or advocate for operationalization of the county AMR coordination committees, ensure that all counties have for those that are already established, ensure that they are fully operationalized with regular meetings and even deliverables, because we have seen a lot of them have their functionalities has reduced because of different challenges. We have seen AMS programs established in the county referral hospitals, but this has not been scaled up to all other hospitals. We advocating for the scaling up of AMS program to all hospitals within the counties for us to be able to ensure that we promote the prudent use. Investing in diagnostics, upgrading laboratory capacity for culture and sensitivity testing is important for us for continued surveillance, and to ensure that we have domestic funding and resource mobilization, embedding AMR in the county development plans, and even in terms of performance expectations from different staff involved in AMR. We're also advocating for integrated surveillance. We have seen other sectors left behind, and this may be a challenge in terms of strengthening the One Health purpose. So the way forward is really to integrate AMR with other health systems so that we ensure future sustainability. And we can see from the health pillars that AMR can span across the different areas of infection prevention and control. We have programs focusing on WASH, programs focusing on IPC and vaccines. AMR can be embedded here because the main focus is on prevention of diseases. We have programs focusing on access to essential health services in terms of affordability and supply. Stewardship and access are critical areas because we have access to essential medicines. We know that when you have availability of the access category, there is less reliance on watch. Timely and diagnosis can also be strengthened through the quality lab systems that have been initiated by the UHC, and this can be a very good driver for AMR mitigation. Quality assured treatment, evidence-based treatments, and restriction over the cell counters. This can be achieved through collaboration with the regulators, professional associations, and so forth. So for us, really, the rallying call is that already there are structures in existence where we can leverage on ensuring that these structures prioritize AMR interventions so that we can be able to pull forward. Otherwise, thank you very much for giving me this opportunity and listening to me. Thank you.
Thank you, Dr. Tanui. I'm sure you can hear the round of applause, and I will request them to do it again a little bit more loudly.
Back to you, Lady.
We know that Kabarak University sits in a place that was set up by Moi, so I'll request that we do the Moi claps, and I'll just give you an example on how it's done. Moja, mbili, tatu, funga, fungua. I want to show you on the funga and fungua parts because some of you may not remember. So we're going to do moja, mbili, tatu, funga, fungua. Okay. So let's give Tanui the Moi claps. Moja, mbili, tatu, funga, fungua. Thank you very much, Dr. Tanui. That's quite an insightful presentation that you gave, starting from where we are at the moment to the point of discussing about the call for action. Clearly, AMR cuts across all areas, and it's important that even at the national level, we are taking the One Health approach to address these issues. Asante sana, Dr. Tanui. We hope that you'll still remain online for more engagement. Ladies and gentlemen, at this point, we want to take a break, a health break, which will be preceded by a photo session, so that we can release our dean, who is very engaged with many other activities. So we'll walk out. I think the team from Kabarak University will lead our guests to the photo spot, and then after that, we'll have our tea, and then we shall resume again in about 20 or so minutes. Karibuni sana for the tea, and let's take a break at this moment. For those that are online, we shall be back here in about 15 to 20 minutes. So we hope that we won't lose you. Asanteni sana.
When you have the perfect response in your head, but your fingers just can't keep up. We've all been typing, deleting, retyping. Now I use Whisper. It's perfect format to text on any Apple website.
Nairobi, Kenya. From Nairobi, Kenya, DJ Sarge.
They are very important to our community, and we can use them so that we can prevent those illegal drugs. Also, we can use our youth, and as a community, as we are here to sit today, we do chair all government activities. And for this, I think even in our barazas, we shall not try to sensitize our community how dangerous it is to use and prescribe the medicine. Thank you.
Thank you very much, Mr. Patrick. And lastly, I would like to ask, how aware is the... Sorry. So how aware is the public about the dangers of AMR?
As I've stated earlier, we should use it in our barazas to state our community. We use the HCVs and also the youth. In most, probably even the churches, we can use them to sensitize our community how dangerous it is to use and prescribe medicines. And all our cooperative, because most of them we do attend. And I've said earlier, we do coordinate all government activities. So in this regard, we shall try our best to inform our community.
Thank you very much for your input. At this moment, I'd like to move to the student representative, and I'll channel a question to Victor. So what misconceptions about antibiotic use are common among young people and students?
Okay. Good afternoon. Allow me to introduce myself once again. My name is Victor 𝐿𝐵𝐵𝑖𝑜. I'll be a fifth-year medical student. Am I audible? Okay, yeah, this is good. I am Victor 𝐿𝐵𝐵𝑖𝑜. I'm a fifth-year medical student at the Egerton University. I have also been fortunate to be in the National World 2025 Youth Reps Consortium, and through that I've been able to have this opportunity to serve as a youth rep. So to answer the question, I think the most common misconception among the youth is the need to use antibiotics even for viral infection, especially flu and other, without proper diagnosis, of course. We tend to rush to antibiotics to the point of using them as prophylaxis, where if you begin manifesting symptoms, you treat yourself before the symptoms become fully fledged. And then something else is that without administration of antibiotics to you, you are somehow undertreated. We understand that that is not true. Not all disease states require pharmacological treatments. So there is that, and then there is the commonplace cessation of treatment once your symptoms have improved. Once you are feeling better, you stop taking your prescription without completing them. Yeah, but these all are because of gaps in information, and with proper stewardship, we can sort that out with time. Thank you.
Okay, thank you very much. Next, I'd like to pose a question to Michelle. So how aware are students of their roles in combating AMR?
Okay, thank you for the question. Awareness is improving among students about AMR, but mainly among the health students, some students still view AMR as an institutional problem and not a personal responsibility. Yeah, so yes, awareness is improving, but it's still lagging. Mainly because some students, we are taught about AMR mainly from human health perspective. We don't know about the animal or the agriculture or those other disciplines that affect AMR. Yeah, so yeah, that way. Thank you.
Thank you very much. Thank you for your input. And lastly, Warren, so how can students contribute to stewardship initiatives during clinical rotation?
Good afternoon again. So as I was introduced earlier on, my name is Warren Nyanyuki, graduating next week from the School of Nursing, Kabarak University. So how students can contribute to stewardship in championing for AMR. Number one, we know that students are the core of most of our hospitals in Kenya. If you go to most of these hospitals, you'll get that the proportion of students to nurses is actually high. So, number one, these students take part in collecting data on patients who are on antibiotics. If the patient has come, let's say, with pneumonia, these students will collect the data. They're responsible for charting the data, how these patients will be using the medication. Number two, the students also play an important role in giving education. You see, the students are left mostly with these patients in hospital. So they give the necessary information on how to use these drugs, the side effects, and other essential information about MR to other students, the nurses, and the patients as well. Also, they champion in passing this information to the community. An example, if Victor here or my friend has this knowledge about MR, he or she is responsible to go and champion in their respective areas. I think that's all.
Right, and as a student, how can you leverage digital platform to promote AMR awareness?
I think that's a good question. And this current generation, the Gen Zs, we have been branded as the social media champions. So with our knowledge on how to use the social media platforms, the Instagram, the TikTok, we can create essential and meaningful content to educate people on how to use drugs, essentially on the resistance. Yeah.
Okay, thank you very much. Thank you so much for the panelists. Thank you for your input. And at this moment, I'd like to invite Dr. Ada to take over.
Thank you so much, Florence. Thank you. We'll get to appreciate my co-moderator for a job well done. Yep. So I think that brings us to the end of our panel discussion. But then I'll ask that you still keep to your seats, because what we are having here, we are having some of our online participants. You know, we could be having some questions from our audience here. But then I think we see some hands being raised. And so I'd like to, if the one hand I can see here, someone by the name Elizabeth Ominde. Elizabeth Ominde, if you can hear us, if you can just unmute and yes, you even have your video on. Kindly ask your question. Thank you. Elizabeth, I think we can't hear you. Let's just check our audio. I don't know whether it's on our end. Okay. Elizabeth?
Can you hear me now?
Yes, now we can hear you. Kindly proceed. Thank you.
Yes, I've been one of the lecturers at the School of Pharmacy. My area of interest is in the quality of medicines. And I was just wondering, because quality is one of the drivers that has been identified for AMR, if any studies have been done on the quality of medicines in our county or in this region to find out what is actually pushing things towards the development of AMR other than misuse of the antibiotics or antimicrobials?
Okay, thank you so much. Thank you so much, Elizabeth, for your question. And kindly allow me to pick on Dr. Lydia. Dr. Lydia, if you could speak to quality of medicines in regards to evidence, whether there's evidence within Nakuru County, within our context here in Nakuru County, in regards to quality of medicines tying to AMR. I can just pass the mic to you. Yeah.
Thank you so much, Dr. 𝐿𝐿𝐻𝐿, for that question. So for Nakuru County specifically, we have not yet started doing the quality tests. At the moment, we rely on the reports from the Pharmacy and Poisons Board. Are you able to hear me? Dr. 𝐿𝐻𝐿, are you able to hear us? Okay. Okay, so at the county level, we have not yet begun doing our quality tests for the antimicrobials. What we rely on at the moment are the reports from the Pharmacy and Poisons Board. They usually do checks once in a while. They come and sample the medicines on our shelves. So they do across the board, antimicrobials and the other medicines. They take samples, they look, they do the in-house checks, and then they submit or they give us the feedback. Just to mention that for the public facilities, we mostly do our medicines from KEMSA and MEDS. And usually they have their own in-house laboratories, and they do the quality checks for the medicines that they stock. So up to this point, we rely heavily on the two suppliers, that whatever they are supplying to us have already undergone the quality checks. The challenge now is in the private market where, particularly if they're obtaining from the other suppliers, I think that is something we'll need to take into consideration moving forward. Thank you, Dr. 𝐿𝐻𝐿, for that question.
Thank you so much. Thank you, Dr. Lydia, for your response. I do believe, I think it's quite clear in regards to the evidence base within our county here, Nakuru County, more needs to be done in terms of evidence generation, as opposed to, I know it's quite in order to rely on the Pharmacy and Poison and KEMSA, as you've mentioned, with the belief that these medicines that are being brought on board that have already undergone, some rigorous, research, and evidence has been gathered to inform what is being done at the county level. So, thank you for that response. I don't know whether we have any other questions online. I think I could only see probably in chat. I don't know whether we have questions within our audience here. Any questions that we'd want to direct to our panelists? Because we have a couple of hands. Someone could just help me pass the mic.
Yeah, thank you. My question to the community, to our assistant chiefs. Patrick, you recognize that farmers are using chemicals. Actually, they are overusing chemicals, as you said. And I would like to know then from your end, what interventions can you do as the community leadership so that you protect the users of these commodities? For example, you said there are people overusing chemicals on tomatoes, potatoes, for sale, and we are the consumers. So then at community level, what can you do? What interventions maybe can be done to protect the consumers and also prevent AMR?
Okay, thanks for that good question. In fact, it's not I will do. I've already started. I've visited all those farmers and I've cautioned them because they're within my area and I know them very well. So it's not something to start. It's already started, but with time, I'll also go on from my area to other areas because this forum has really educated me. So I'll do as my level best as I can. Thank you. I think my colleague here, Madam Susan, is ready to add something.
Adding on that question, we have always been working with the agriculture extension officers to sensitize the community on usage of those herbicides or other fungicides. So they have been sensitizing them in the barazas. We have been visiting those farms with her, or rather with them, because they are much aware more than ourselves. They know those herbicides which they are aware, they know them, and there's also this board, PPB. You know, sometimes we are calling you, say BBB. So. She also goes around sensitizing the community about that in that board, and whenever even those herbicides, they usually throw them to the rivers. They don't even dispose them properly well, so they always sensitize the community on that. So we work hand in hand with the extension in agriculture officers.
No, thank you so much for that response. I think what is coming out clearly, I think Madam Susan has softened it in that it's sensitization. But it came out more strongly from Bwana Mbugua. He talked of cautioning the farmers. I think that he just meant sensitization, creation, awareness creation. So I think that is, yeah, kindly, okay. Yeah, we do have Bwana Kefa. I think he has a response for you.
Thank you very much. There has been what we call Ukulima True campaign, where the community has been sensitized on the safe use of pesticides, safe use and disposal. And in fact, PCPB said that they are having the collection centers of the used cans. So maybe after usage, the farmer is supposed to perforate the can and then take it back to where he bought it. Because there are many cases whereby the farmers are using those cans to drink tea, they're using those cans to store food, even to the milk. And have an example, just here in Gata, there's the workers there, they're using the Widol can to carry milk to their houses. So when I went there, I just perforated them there. Even though it was very harsh, but it was at least safer. I did a very safer thing to do it. So the Ukulima True is doing the campaign to sensitize farmers together with the Department of Agriculture so that the farmers can be able to know how to use the pesticides. And also we have trained spray service providers in the communities, because we find that nowadays even the women, children maybe under 10, they're spraying the pesticide, which is very bad. They don't use the recommended PPEs. So these spray service providers have been trained by the government and 𝘚𝐵𝐵 to offer spraying services to the community so that they know how to measure and apply those pesticides to the intended purpose. Thank you.
Thank you so much. Thank you so much, Bwana Kefa, for your response. I don't know whether we are still having, I think we can take one more. You have a question, Doc, kindly, Dr. Tony. You could just pose your question, and then I think we'll take, two more.
Thank you very much for the great insights from the various sectors. My question to Simon. I think there's quite a lot that is happening within the environment, particularly with the waste disposal. I think that is a great concern even to everyone here, and especially at the dump sites. So maybe you could expound or give us some hope about what initiatives are happening, particularly to address this problem of waste, and particularly with the focus of AMR.
Thank you, Dr. Tanui. As a county government of Nakuru, we are working on now moving from having an open landfill site in 𝐿𝐴𝐷 to developing a material recovery center in 𝐿𝐴𝐷. The county government has acquired 25 acres, and now they are in the process of working with private partners. For us as the county, we are just going to develop the infrastructure, but now other waste handlers will come in to offer. Maybe if there is a person who is dealing with organic waste, will come there. Others who are dealing in converting waste into raw materials, recyclers, and reclaimers. So we are now moving from even adopting the Sustainable Waste Management Act for 2024, which has brought about the concept of extended producer responsibility. So we are working with even pharmaceuticals and agrochemicals through the CropLife Kenya. CropLife Kenya is the umbrella body of all agrochemical manufacturers in Kenya, whereby they are now coming up with the take-back mechanisms of all their agricultural, the agrochemicals, hizo containers ambazo wakulima wananunua zinaweza kurudi back to the company for safe disposal, because we that is a pathway to AMR, because farmers are enlightened on how to dispose ama hawana the proper incinerators. So CropLife is putting up small hubs within the sub-counties, but now they are developing a bigger hub in Nakuru, such that hizo containers zikitumika na wakulima zinarudi Nakuru and they are taken to the river for disposal. So what has held us back is the EPR was there is a court case ongoing, because many of the companies know that once that is effected, itakuwa an extra cost, because all companies will be mandated to ensure that there are no products of theirs to the environment. So it will be their responsibility to ensure that they clean up, and kutakuwa na hiyo take back mechanism. So once that is effected, I'm sure we are moving towards a good future.
You have another question. So thank you so much, Bwana Simon, for your response to Dr. Tonyu's question. Yeah, so let's take one question. Yeah, okay. We'll take one more. Kindly continue, proceed.
Oh, pardon, is it me or?
No, it's you. It's you.
Oh,
with the mic, yeah.
Thank you so much. My name is Engineer Daniel Rotich, and also I'm a researcher. First of all, I must admit that I'm a victim of these drugs. In my cupboard at home, mi niko na watoto wadogo wawili, and niko na kama kwa mfano kwa upande wa the issue of paracetamol. Kwa paracetamol niko na Calpol, niko na ingine sijui, yani majina hata ni mingi. When I talk in the issue of antibiotics, niko na Amoxiclav iko hapo, niko na Zicet, and to be honest, this issue is real. Okay, let me talk in an engineering perspective. For example, as an engineer, what I know, two boreholes which are near to each other, they possibly share aquifer, and according to what is known as by the engineers, the transmission by the Darcy's law, some of these bacteria can move swiftly and cause issues with our environment. I also know in the design of soak pits, for example, bad designed soak pits can lead to those effects. In issue of water, let's say water pipelines, old water pipes can create what is known as biofilm, and that biofilm can cover these resistant microbes. For example, in rapids and filters, when I talk of design of water treatment plants, a bad design treatment can also be a medium of these enhanced these resistant microbes. So my question or a comment is, how do all professionals, the technical, the engineers, those doctors, pharmacists, can come and agree on one thing and move forward so that we can prevent life and make sure that our future is sustainable? Thank you so much.
Thank you so much, Bwana Rotich, for your question. Thank you so much. And I think you've brought in a very interesting engineering perspective. And I think it ties to what was actually presented by Simon in terms of what is going on in the environment. Issues of, you talk of aquifers being near each other and causing, the leachate, the runoff. He spoke on surface runoff, issues of dump sites. So I don't know who amongst our panelists can I think what Daniel is alluding to is basically the One Health approach that you're talking about. Even though now our One Health approach, we've been mentioning a lot on human health, animal health, agriculture and environment. And I know you feel like engineering is missing out. Yeah. So, and other practitioners, we know that there are so many other people, so many actors that we can bring on board to address this issue of AMR challenge. I'm tempted to still come to you, Dr. Lydia, but then, yes, please.
Thank you. Thank you so much, Engineer, for that question. And actually, when you look at the concept of One Health, it does not just mean the 4 departments. Usually, when you look at the 𝐶𝐶IC, we are required to co-opt the various technical persons into the committee. So it's just that our 𝐶𝐶IC is still young and growing. As members of the 𝐶𝐶IC, we also need, I can clearly see we need an engineer. The second time that question is coming up. 2 weeks ago, when we were sensitizing our county leadership, we had the director, mechanization. There was another engineer in the Department of Agriculture who also had a comment on the same, that he could see very clearly how engineering plays a role in the fight against AMR. And so we definitely need to co-opt an engineer, and we can have discussions after this during lunch behind the tent. And just to mention that we need to co-opt all other people trade. We've really heard how, the products getting into the market, the imports being affected. So we also need to co-opt many other members, religious leaders, our administration, our chiefs who are in attendance. You also need to be members of our 𝐶𝐶IC. So that when you're coming up with this organization, when we are doing the World Antimicrobial Awareness Week, give us ideas on how to reach the public in a better way. You see, from where some of us sit, we interact with the public at the hospital, yeah, when they are sick. But you see, there is a very big population that we are not impacting. So we really need your input in our 𝐶𝐶IC and in this fight against AMR. Thank you very much.
No, thank you so much, Dr. Lydia, for your response. And I know, just as you mentioned, One Health approach, as much as we talk of human, animal, and environment, the environmental bit, coming from a public health point of view, we have environmental engineers. Yeah, so engineering is usually a critical aspect of the One Health approach. They're not left out. These are environmental engineers, but at the same time, they are public health practitioners. They are health professionals to a certain extent. And so I do feel that it's important, as you mentioned, probably with 𝐶𝐶IC and at the national level, NASIC, important to then co-opt engineering aspects and perspectives. So thank you so much for your response. Yeah, so let me just take one last question, I think, from the lady. I think she had her hand up a long while ago. Yeah.
Thank you so much. My name is 𝐊𝐴𝐼𝐻𝐼𝐻. I am a final year student of medicine at Egerton University, and I had 2 questions and an input. So I don't know, this is maybe to Dr. Lydia. what other regulations are there? What other regulations have been set aside apart from the sensitization of these entities that keep on dispensing drugs even without prescriptions? Are there any laws that seek to protect the people or rather to govern our clients? And then the other one is on, I think, the environment. I was once in a community outreach activity, the CHPs, the community health promoters, and we came across some site whereby there was a lot of dumping of solid waste. And I inquired, and they said that the company or the factory rather that does that is because they say that the dumping site that has been set for that specific region is quite far. So this question to Mr. Simon, they were saying you're coming up with a dumping site, acres of land. How then do we ensure that? Because if you set aside this dumping site so far out of town, people will still find this as a challenge, the cost of transporting the waste. So then will you have like a central place whereby the companies now collect the waste for it to be dumped, or what is the plan? Again, to Dr. Lydia, who is the focal point, I feel like the youth are not being engaged as required. You know, it's not, okay, recently, 2 weeks ago, we had the WOW Week and we had the youth walk. What measures are being placed apart from just that? You know, we always sit and wait till the next year, WOW 2026, we do a youth walk. I feel like you can also engage the young people, create poster competitions, create essays, research, and then reward these young people. You know, these young people bring in the minds, they have ideas, but then also they need to see the reward. Reward them, the essays, yeah, thank you.
Thank you, thank you. You know, great perspectives from our final year student. Great. So Lydia, Dr. Lydia, we may just start with you.
Thank you very, very much for those questions. So the first question on the regulation of the antibiotics. So antibiotics, so yes, we have laws in place. Very specifically, we have our Pharmacy and Poisons Act, and you'll find that antibiotics are in the Schedule 4, that is prescription-only medicines. And just like all other laws, the challenge is enforcement in our country, because when you go to many jurisdictions, even here, South Africa, Dr. Nyandoro will tell you, sorry to put you on the spot, you cannot access an antibiotic without a prescription. So basically what you're saying, sorry, is that we need to enforce our legislation. And so we are looking towards a scenario where moving forward, Nakuru County could be one of the pioneer counties where we will say through our county assembly, so we are still in that journey, where we can even lobby, just as we are having this conversation here, we hope to have the same conversations with our county assembly, where we can pose the question, since you're having a lot of AMR, we've heard about what is happening in agriculture, in the animal sector and in the environment, why can't we be the pioneer county where prescriptions will only, antibiotics, then that is across the spectrum, human, animal, etc., can only be accessed through a prescription. So those conversations begin here, yeah? If we could, move from today, and the next point is to engage our county assembly, because they're the ones who make laws within the county, isn't it? Yes. So those are things that we are hoping to achieve moving forward. But then that must come from the public, must come from CASIC. The second question was on the youth engagement. Yes, that's a gap in our CASIC. Okay, at the national level, there's a very strong youth advocacy committee. In our county, not yet. We had engaged several clubs. We have a One Health club at the Egerton University. Dr. Victor, I've given you the title, Ali. Yes, to be, you can engage us on the same. We also have a Heroes Club here in Kabarak University. So
we had fronted them as our youth advocacy. And also KMTC, they came strongly this year in advocating for the work. So what we need moving forward is a stronger youth committee beyond the WOW week, and we've taken that into consideration. And we would like volunteers, maybe also you can have a conversation as we proceed for lunch on the same. The only challenge is that the youths we are getting are students. So once they graduate, they relocate out of Nakuru, we lose touch. So if we could get ideas on how to go about that, it would be great. Thank you.
Thank you so much. I just wanted to clarify what we have now in 𝐿𝐴𝐷𝑚, that is a dump site. But what we are proposing to have is a material recovery center, which is different from a dump site. In a material recovery center, you have different players in waste agripreneurs who convert waste into resources, coming together and turning that waste into a resource. Kuna wale wanatengeneza briquettes, others make street lights poles and etc. So for those partners, they will be coming to have their own go-downs in the material recovery center, but waste will be transported by waste service providers. In every sub-county, tuko na service providers wenye wana operate mpaka saa hii. They usually transport waste to here, to the dump site. For the partners wenye watakuja, they have no issue taking the waste to Gilgil because to them that waste is a resource. Saizi atuangalie waste kama takataka. It is the same way you can find a company in along Salga. They transport the pozzolana from Kajiado to Upper Nakuru so that they can make cement. So, kwa waste agripreneurs, they can even transport waste from here to Gilgil because they know that waste is bringing in money. It is becoming a resource. Ndio tunasema siku hizi taka ni mali. And they are willing to do that. The only thing they want is a space and the right infrastructure to do it. If you move to the development, that is what they are doing. Ndio tunataka tuelekea hapo na EPR pia itatusaidia kufika hapo. Thank you.
Thank you, Simon. I just wanted to say two things. Now that we are in a learning institution, I think it's important to mention that at the national level, there is a pre-service course on AMR and AMS that is being piloted at the USIU. And so moving forward, we hope that as medical practitioners are undergoing training, they will also be receiving training on antimicrobial resistance pre-service, so that by the time they are coming into the market, they are ready, they know what to do. Even when they are posted on their own to the various facilities, they'll go and establish these important structures in place. And then number two, we forgot to recognize the 𝐿𝐴𝐷𝑚. There are several members of the 𝐿𝐴𝐷𝑚 in the house. So if you're a member of 𝐿𝐴𝐷𝑚, please stand up, we acknowledge you. Yes,
yeah, and I do believe, Dr. Lydia, proper recognition will come. Yeah.
Thank you very much.
Thank you.
Would you like us to introduce them, or?
I think there will be a session for that. Yeah, we definitely want to see who are these members, because we have it here, 𝐶𝐶𝐵, and everybody is interested in wanting to know who are these 𝐶𝐶𝐵 members. Yeah, so thank you so much, and thank you for your questions once again. And I think in a different forum, we had a discussion about meaningful youth engagement. So right now, I hope you guys, as student representatives, you don't take this as being tokenistic. Is that the word you are using? Yeah, this is in a way meaningful in really getting to hear about your perspectives in regards to the AMR challenge. So I'd like to bring our panel discussion to a close, and even as we are winding up, we have to appreciate our panelists who are still here with us, so that then I allow them to get off the stage, right? So now that we've done several 𝐿𝐴𝐷𝑚 claps, I would want to us to do a special, 3 hearty claps for them in a special way. Yeah. The special way I'm talking about is, let's gather it and make sure it's long enough. Yeah. So you have to give them 3 good enough claps. So 1, 2, and 3. Thank you so much. So thank you. We truly appreciate. Great to hear from our national administration in terms of giving us that community perspective, and from our students. Even though we wish we had, a lengthier time, so that then we could have further discussions. But then the conversation doesn't stop here. We keep on conversing. So thank you so much, and I truly appreciate the questions that have come in. I do feel that the panel discussion in a way has allowed us to shed light more into, especially with a focus on a One Health approach. I think we heard from the, the human health aspect, we heard from animal health, from our very able Dr. Ndegwa there. We've heard from, agriculture and environment from Simon and Kefa, and from county, the community perspective. So thank you so much. So I'd like to now I know there's so much, but then I don't want to go. I have so much in terms of notes, and I do hope we have a repertoire. We've taken in so much. So let me not break it down in terms of the key takeaways, because there are so many. Yeah. But then to just appreciate our panelists. Thank you for your insights. Again, you've just made it very clear to us that the interconnectedness between all these sectors, there's a concern that has been raised here, importance of including engineers in this conversation. And I think it also goes into, I could also think of a place where lawyers can play a role in terms of, issues of over-the-counter drug access, in terms of ease of access for this. So there are various actors that we need to come on board towards addressing this AMR challenge. So with that, I'd like to stop there and hand over to our main MC here, Dr. Mogesi Mokaya. Thank you.
Thank you very much, Arthur. Thank you very much. Let's give Arthur Obama claps as he goes to sit down. Behave like Obama, like that. Yes, exactly. There you go. Very well, Arthur. Asante sana. So, ladies and gentlemen, being a nutritionist, I know that our glucose levels are dropping. We might get irritable, and our thinking may not be optimal. So at this point, I wish to invite us for lunch. But before we take lunch, I will request that one of our students who is here to put us in prayer to grace the food. And I will request that you pray for us. You know who I'm talking about, no? Yes, please pray for us. Faith Joy. Pray for the meal, then I can give directions after that.
Yehova mwenye enzi kuu, tunakuja mbele zako wakati huu kushukuru kwa kuwa umeweza kutulinda kutoka vile tulianza. Tumeweza kujifunza mambo mengi. Tunakuomba uweze kutusaidia tuweze kutafakari yale yote ambayo tumejifunza na tuweze kuyatumia katika maisha yetu ya kila siku. Tunapoenda kukula pia, naomba uweze kusaidia chakula ambacho tunaenda kukula kiweze kuboresha miili yetu, na tunakuomba uweze kutuchunga hadi tutakaporudi, na sala hii iweze kukufikia kupitia mwana wako ambaye ni mfalme na kiongozi wetu Yesu Kristo. Amen.
Amen. Ni lini mlisikia Kiswahili sanifu kama hicho? Tunashukuru sana. Wakati huu tunataka kualika kwa mlo wa alfajiri. Mlo utapatikana pale kwenye cafeteria ya university. Cafeteria inaitwaje? Chumba cha mlo cha university. Wengine wetu ambao ni wenyeji hapa katika chuo kikuu cha Kabarak tutaelekeza ili tujipe mlo. I think I'll stop at that point. And so the lunch is going to be offered at the cafeteria. We will have our colleagues standing at the exits shall give you the meal cards that shall identify you at the cafeteria. Enjoy your lunch I'm kindly requesting that we make it hasty so that we are back here for 2 more sessions.
Had quite the representation, and then here we are doing the representing our institution in this symposium. We are very delighted to be here, and most of my colleagues have stepped out. They thought there's nothing else after lunch, but still happy to be here. We are quite a number of us remaining. And yes, we are looking to further better involvement in engaging the youth in antimicrobial resistance campaigns. So, on to our presentation. This is on behalf of the One Health Club. So this abbreviation here, it's One Health Club, nothing really. So, I'll be doing more of a storytelling. This is a run-through of how the world was before antibiotics, what happened after, during, and to this point of antibiotics, and how the world might be when we've lost antibiotics by mechanisms of resistance. So it's a presentation prepared from the book Miracle Cure by Dr. William Rosen. I really ask people in health to read that book. It's insightful, it's entertaining, it's really well written. I told a colleague of mine it's cinematic, and yeah, I can attest to that. So this is the world before antibiotics. That is an illustration of a previous medical procedure known as bloodletting. When medicine was starting, procedures were things like this. It was believed that disease came from bad humors, bad imbalances of the fluids in your body, or bad air. We learned that from malaria. It literally translates to bad air. Before people could determine where disease comes from, especially infectious disease and their associated pathogens. This is what they thought, and they thought that if you're sick, we should just poke a hole in you and let out some blood, because it's the blood that's making you sick, so you're going to be fine. That's bloodletting. And then we have had prominent figures in history. We've lost prominent figures to infectious disease. One of them is 𝐊𝐶𝐞𝐲, the son of the 30th president of the United States. He had a blister, something you get nearly any other day, and you succumb to it. George Washington, he lost his life to acute epiglottitis. People, the doctors of that time, they tried to come up with explanations. They said that he had been in the cold, he had been traveling in the cold, in the rain, so it initiated a sequence of events that led to his death, but retrospective diagnostics have determined that it was mere acute epiglottitis, something we treat these days with antibiotics, something we cannot even imagine succumbing to. So that was heroic medicine. It did more harm than it healed. And that had been accepted as normal. So this here is a child. This is impetigo, a term at that time that referred to staph or strep skin infections. This is it. You can see this. And even would you have been lucky to heal, you would have been left utterly disfigured. So medicine was guesswork. It was not scientific. Try and error. We try, we fail. We see what we do, what we cannot do. And all this, like I've said, initially is before people discovered that diseases are caused by germs, the germ theory of disease. Hospitals were places you were sent to. Therapy at then was generally palliative. You were, once you caught an infection, you were doomed to die. It was inevitable. You would be lucky if you survived, but you were doomed to die. So, and infections were the commonplace killers, not like during this time and age where we have the NCDs, the cancers, the lifestyle diseases, which are very much within our control preventatively, and even once we acquire them, we still have some degree of control. At this time, before antibiotics came, infections were the killers. So we'd have pneumonia, TB, wounds from accidents, wounds from surgeries, wounds from delivery. They were easily lethal, just like childbirth sepsis, things like those, and they were very normal. It was something else that society had accepted as normal. That's it. And then on this slide, we have an illustration of something that people would put on their doors. If you had someone in your house who had an infectious disease, say scarlet fever, especially scarlet fever, you'd have this warning sign of sorts on your door. You warn visitors that you have someone with scarlet fever, you should keep off while you are in. Poliomyelitis, diphtheria, things we never hear of today were normal back then. And then children were put in isolation for extended periods. They would have death chairs even for children. You can imagine how traumatizing that can be. TB, because you didn't have medical pharmacological therapy, they believed that you could go and take clean air. Go elsewhere and take clean air, and you'll be fine. So there was that. Youth mortality, we said, as we've alluded to, and life expectancy, 40 to 45 years. We can't believe that in this age we are telling ourselves that life begins at 40, but at this time, it ended at 40. So now some light started coming with antibiotics. Before penicillin, we had synthetic antibiotics, the sulfur drugs. They actually came before penicillin. And then the German industrial chemist is the one who discovered that these things could actually work and not harm the body. Initially, they'd use mercury. They'd use mercury on you if you had a bacterial infection. And we understand the toxicity profile of mercury. And once they started seeing the side effects, like you'd be salivating, you'd be those mental adverse effects of mercury, the doctors of that age would actually be excited that their medicine is working. But Paul Ehrlich, he discovered that you can have medications which do not negatively harm the host. They only target, that's the concept of magic bullets. It's German mythology, yeah, where the bullets only attack the enemy, not the host. And then so that's how sulfur drugs came, and then penicillin. This is probably everybody's favorite scientist, Sir Alexander Fleming. He accidentally discovered penicillin, 1928. He was working on, I think it was a staphylococci, and then he left the dishes all over the place, and he came back from a holiday, found that they were not growing, and it was a penicillium mold just around there that had caused that. So it started the series of events that would give us penicillin as an antibiotic eventually. But it wasn't easy. It was difficult to purify and obtain in large quantities. That's where these three other less mentioned scientists' efforts come in, and they determined how we can produce penicillin at scale. And then People were treated. It was working magic. And then that was around the time of World War I. So with that urgency came the need to have more production and things like that. So the production of penicillin industrially went really high. So antibiotics changed everything. We've had this from the start of this symposium. Surgery, childbirth, it made it safer, and immunotherapy, transplantation, intensive care. We have seen this, and we should work really hard to ensure we don't lose this. We doubled the average life expectancy. We've said earlier that life ended at 40, but because of antibiotics, we recorded twice that. And then with that, of course, everybody was very happy. This is Surgeon General William Stewart. These are his words. The time has come to close the book on infectious diseases. We've basically wiped out infection in the United States. This is the impact that the magic of antibiotics had. It had people saying these things. We had finally eradicated disease. This another from Dr. Robert Petersdorf. He'd say, I cannot conceive of the need to have 309 more graduating trainees in infectious disease unless they spend their time culturing each other. So yeah, this is the magic that antibiotics really did. And we can understand from, it's like God sent, because how do you double average life expectancy for everyone? Yeah. And then Sir Alexander Fleming, in his genius, he predicted resistance way before the first case was even recorded. This is a snippet from what this journal said of him. I think this was from his Nobel Peace Prize speech while he was being awarded for the discovery of penicillin. If you can look closely, you can see here he's saying there's danger that the user will not take sufficient quantity to kill the germ. How he may pass the germ along to a next door neighbor who in turn will pass the germ to someone else, and the germ will develop immunity to the drug. So in as much as penicillin came with its magic, its resistance to it developed in as rapid as 4 years. And then ever since that time, every other antibiotic that has been generated has met resistant strains. And then with the research and microbiology and biotech, scientists discovered that R factors, I think this R stands for resistance, R factors are shared bugs. And not just between specific species, it can be interspecific, meaning P. aeruginosa can pass resistance to Klebsiella. That speaks to the danger we are facing. And then AMR was sped up by mass agricultural use, overprescription, things we do, things we are guilty of. Cosmetic use. I did not know antibiotics are put in cosmetics. I did not know that, but we learn every day. So yeah, this resistance and the trouble that it would bring to us was predicted really early. This is a timeline of discovery and resistance. You see from the time of the discovery of penicillin to around there, the methicillin fluoroquinolones, that's referred to as the golden age of antibiotics. After the discovery of penicillin, it was a sort of upward spiral. Drugs were discovered everywhere all the time. So it continued. We had so many drugs for everything. Even when the resistance for penicillin came, we had things to treat it with. That's why we never took it seriously. And then from the time of fluoroquinolones, we've not had much in the pipeline. As Dr. Leader said, we've only had 𝘱𝑗𝑥𝑘, and that was in 2015. And I can put my word to it that we already have resistance with that too. So from our century, the 21st century, we've not had a lot of resistance new antibiotics. We can see on the other timeline the resistance. Penicillin resistant Staph aureus as early as 1947, vancomycin resistant enterococci, MRSA, we are familiar with MRSA. And then onwards, it has been projected to keep only rising in hospitals, in our community, unless we take reasonable action. Okay, where are we today? This is a culture and sensitivity strip of vancomycin-dependent enterococci. It means it uses our weapons as food. It eats vancomycin for its nourishment. So we've alluded to MRSA, VRE, VDE, self-resistant Neisseria gonorrhoeae, CRE, multi-drug resistant Acinetobacter, aeruginosa, fluconazole-resistant Candida. We tend to think that resistance only occurs in bacteria. Turns out it also does in higher organisms. And then TB, XDR TB. This is a simple graph of how antibiotics are used in the world. I was also not familiar with this. I thought antibiotics are only for human use. I never imagined that our livestock are given antibiotics in their food. Only came to realize that is true for growth promotion. So you give your chicken, your cows, your goats antibiotics in their food to eliminate the low-grade inflammation so that they grow faster, they spend more energy than fighting infection. So this is what we are doing in the world today. And then in the hospitals, about 50% antibiotics are prescribed unnecessarily. And these are figures from the United States. We don't have much data on our state locally, but we can do extrapolations and see where our state is. And yet again, we can see that resistance, the sub-Saharan Africa is marginally affected. We had over 4.4 million deaths in Africa alone out of the 5 million globally. So we can tell of the state that we are in. And then a number of factors contribute to this. Something else is antibiotic market dynamics. I heard this from a TED talk. If you're an antibiotic drug manufacturer, you won't be creating something. That something is an antibiotic, which you'll administer to a patient, and it offers cure, and that's it. You'll purpose to create drugs for conditions which are somehow lifelong. Chronic diseases, hypertension, diabetes, you'll focus there. That's why Big Pharma right now, that's the attention. We understand this. That's why there's not so much production of antibiotics. No, not much research is going into that. The FDA also runs a strict criteria to limit the number of people in the industry. And I heard that before an antibiotic is approved, there's at least 30,000 pages of documentation to be gone through. You can understand the toll of that. That's why manufacturers are discouraged, even if they would have one. So this is an example of someone we've lost to resistance. This is a 20-year-old Brazilian model. She was 20 at the time of her demise. This was in 2009. She contracted what is seemingly a normal UTI, but it blew up they had to first amputate her limbs to try and save her, but not much could be done. She eventually lost her life. And we keep talking of resistance as if it's something in the distant. But for some of us, it's already happening. For some bacteria, the bacteria are already winning. And because it's our future we are fighting for, I think it's necessary that we up our game. So this is what's likely to happen if we do nothing. We'll return to back then when infections were what killed people like normal. We'll lose the life expectancy. Everything will be risky. Surgeons will refuse to take surgeries. ICUs, we don't know what state will be there. Neonatal sepsis will be losing children. And we are already seeing resistance, TB, the UTIs, respiratory infections, already, marginally. But not all is lost. There's a lot of things we can do. I keep preaching the gospel of information. I think we know better. We act better when we know better. And from the foregoing, we can see the toll that antimicrobial resistance is taking on our species. The bacteria are fighting for their own sake. Why won't we fight for our own? It's, as I was getting interested in microbiology, I wondered how bacteria could be so intelligent, but it all came down to evolution. If we will not fight to preserve ourselves, we will be eliminated. So this what we can do. We have alluded to all this enough. Stewardship, diagnostics, we understand IPC, we understand AWARE, we understand all these things. Legislation, especially agriculture, environment, research. We need to understand what's going on, what's beyond our visible spectrum that is going on promoting surveillance. We need to use data and fortify One Health. We need this. We won't make this if we're only playing from human health or animal health. We need to come together to combine efforts in this regard. And then new therapies. That is it from Egerton University.
Thank you very much.
Thank you so
Let's
much.
give Victor a round of applause. Thank you, Victor, for taking us back into time and understanding where we are at the moment, and quite live and interesting perspectives we can actually connect with at different levels or in different people. So let's give Victor another round of applause. Victor, you can do the Obama claps until he sits down. Let's go on until he sits down. Victor, behave like Obama. Wave at him. High five. Thank you very much. That's quite an insightful, taking us back into a historical perspective to AMR. Asante sana. This is our next doctor, and you bet he will have understood all these dynamics that are very important in our lives. Ladies and gentlemen, kilicho na mwanzo hakikosi mwisho. Nonetheless, we want to catch a few things. I will request that we just have a few perspectives in terms of actions that we are thinking about. At this point, I will put the focal persons at the focus, that they mention any actions that are worth our notes in terms of research, in terms of taking this to the next level. I know that there are not so many that are here. The focal persons or the people that sit in the CASIC that are here, we will request that where is the roaming mic? It's here. If you can pass it around. And then it will culminate at Dr. Lydia's desk. So if you can have the members of the CASIC team or focal persons just to give us one highlight in terms of action in your area or that you think is of importance, both in action and in research. Yes, Dr. Lydia, it's back to you.
Okay, I can see Dr. Ndegwa has left, same to Kefa. So for me, the action points are the composition of our CASIC. We need to expand it. There were requests to have an engineer on board, members of the community representatives on board, lawyers, people in the law space to advise us, religious groups, and even representatives from the learning institutions. So we need to expand our CASIC membership. Excuse me. That was one of the action points from this symposium. When it comes to research, a number of ideas have come up, and among them being, in addition to surveillance, because that is one area we were already thinking about, there's a lot of interest also in the environment sector. We need to see some potential areas that we can leverage on, or low-hanging fruits, particularly with regards to disposal of the antibiotics. For me, that is one of the action points from today. Thank you. I would request also maybe members of our CASIC can also contribute. Maybe they can raise their hand and the microphone can be...
Definitely, yes, yes. So we can go to the focal persons, then we can go to the members of the CASIC, and then we shall open it up to the rest of the members here. I know people from Valley Hospital are preparing for something. Please go ahead. Thank you.
Thank you, Dr. I think on my side, my action points mostly will rely on creating more awareness. Huko nje watu hawajui hata EMR ni nini, and sometimes you even see it for just a layman person. Even people who are learned, they don't know what EMR means. And being told that by 2050 AMR will be the leading pandemic, then I need the action point number one for me is awareness on how the right prescription, right dosage, and maybe even the right way of the right time to use these antibiotics and how to safely dispose them. So hapo kwa awareness ndio naona izidi kabisa. It's not only about this work, it should be throughout. Thank you.
Thank you very much. You can pass on to the next. You can, yeah.
Yes, if I can say something about what I've seen as an action for this symposium, I can say even about compliance. I think that is an area also we should try and tighten up. If we have heard from the chief, the way he has said that there are some people who plant these foods there at the local level, and when it reaches us, we are the consumers of that food, and they plant theirs. No, that one is not in line. I would like that one also to be considered as something which can be an action whereby you'll be strengthened up. Thank you.
Thank you very much. Let's pass on the mic.
Good evening. I'm Sarah Mutahi. I'm a fisheries officer working for the County Government of Nakuru. I'm a CASIC member, and I'm also a youth a champion for AMR food systems, anything food and nutrition. And I don't want to repeat what has been said, but on matters awareness, if need be, self-fear. Me, I tell my family, you will die. I don't tell them you'll develop resistance. Because we had a situation where our grandmother passed away, and I happened to be the people who are processing the papers. When I talked to the doctor, they said she had some kind of resistance to medication. I didn't need to know much. But when I go home, I tell them, she did not die because she was sick. It is because there was no medicine for her. She developed resistance because of misuse of antibiotics. I've grown seeing her misuse. I didn't know the word misuse back then, but I knew how she was taking medicine was not the right way. Something else also, I remember when I was 13, I once went to a chemist. I had some breakouts, some pimples, and I didn't even ask for medication, and she gave me something called Doxy. I believe that is an antibiotic. I didn't even ask for it, but my mother knew about it, and she went and talked to that lady. She knew something about medicine, and I did not know, but me, I was willing to take anything just to clear some pimples. And then later, my mom told me that when you use this, she used to call them strong medications, once you get sick, there will be no medicine to treat you because your body will have gotten used to whatever that would have been there to help you. So I would say, me knowing about AMR, back then I didn't know about it, AMR, but that information was being instilled in me without having the label AMR. So as much as we are saying about awareness, it's not about the youth, even the children. I remember as a kid, there was a poem about HIV and AIDS. I got to learn about HIV and AIDS even without going to school to be taught about it. So the same thing about misuse of antimicrobials. We can have it from the kids to teenagers to us youth, because I believe we are the most vulnerable stakeholders. We don't have a future if we have no medicine for us. Simple infections will kill us. So yes, I endorse the message that it's a silent pandemic. And as youths, we are the drivers of behavior change, future professionals, and if we work together and everybody do their part, I don't say we'll eradicate, but I believe there's hope for us.
Thank you very much, Mutahi. Now I get what your colleague meant by saying that you needed 1 hour session, and I trust his word. Let's go to engineer. You must be having something in your mind. Are you, which type of engineer are you? Chemical?
I'm just a civil engineer.
I'm an engineer, kama nani, one of our politicians.
Anyway, I don't want to get into politics, but what I know is that, okay, I'm a civil engineer in the background.
Thank you.
You caught me off guard, but I always have something to say. In engineering, there's what is called contract management. And in contract management, in worldwide, it is known as FIDIC contract principles that we use. And in that FIDIC principles, there's called force majeure. Force majeure is something that comes and stops the projects we are doing immediately. For example, Corona. When Corona came, all the projects that was stalled. For example, I was in a dam, and that time, the materials, I was in Twake Multipurpose Dam, which is the biggest dam in Kenya by that time. So there are materials for construction that were coming from China, from Europe, but because of the issues of regulations, it had to stop. And when it stopped, which means the project stalled, the government came and gave what is called regulations. By that time, it was known as ex gratia, a 2 years extra period for the good of the project, because in contract, when you didn't finish with upon the finishing timeline, then you are supposed to pay back because you had not complied with the compliance that you must finish the project that time. But with the ex-gratia period, that's the time that the contractor went ahead and tried and at 94%. The project has not finished. So what I'm saying is that this issue of resistance to drugs, to other things, it can even cause projects to stall because of the problem with with the drugs that we use. So if the health system fails, even the projects and the infrastructure fails. And that means, as the president has said, that we want in the next 30 or 20 years, we become like Singapore. So if we don't manage the microbials or the microbes, antimicrobes, then by the year 2050, Kenya will still be the same because now the projects will have stalled. Thank you so much.
Now that's an engineer's brain. You see the spiral effect he's talking about, that without human labor, we cannot have development, in short. I like it that you brought about many things, the Vedic principles, the post-mature, and many others. Asante sana, engineer. Indeed, the future of the country is largely dependent on human power. And without human power that is healthy, then we may not get where we needed to get to in terms of development. Any other person who has take-home message? I know the team from, yes. Let's pass the mic, please, to the lady. Sorry, I missed your name. And I'm sure after that, you'll pass the mic behind you to our colleagues.
Good afternoon.
Yes, good afternoon.
Yes, my name is 𝐊𝐿𝐴𝐿. I'm a medical microbiologist working in PGH Nakuru. So for me, what I can only say as an action point for today is just testing, because we know without testing, we cannot identify the infectious agent, which is a bacteria in that case. And so we go on using whichever antibiotics, and in most cases we say broad-spectrum antibiotics. And so the moment we use the broad-spectrum antibiotics, that's where the resistance comes in. And on the other side, again, we talk of research. And so without data from this testing, we cannot do a research. Because we have to collect data from testing, then we see the resistance, and then now we can do a research on it. And that's where we got the percentage of resistance and susceptibility. We are talking of MRSA being 51% resistant. Yes, that was the data as for this year. That's between January to November 2025, which is a national for our country. Yes, Nakuru was part of the testing site, which produced the same results. And so for even Nakuru itself, it was 51%. Then the entire country, it was 51%. So before we take the antibiotics, let's test first the infection. Then we do susceptibility testing. We come up with the susceptible drugs, which we are able to use. And at the same time, we see which are the resistant drugs. Thank you.
Thank you very much. Thank you very much, 𝐿𝐴𝐿, is it? Yes, thank you very much. Of course, that brings important perspective to think about this. To do the right thing, it's got to be expensive. Are we ready to invest into that? And that's a question that probably when the mic comes back to Lydia, she'll be able to respond to that. Our team from Valley.
Good evening.
Good evening, good evening.
My name is Boniface. I'm an infection preventionist. And I want to say this, that we have been talking about antimicrobial, but without IPC, there is no antimicrobial awareness. Because when I look at in this room, there's a lot of opportunities to improve on infection prevention. But I don't see any opportunity to improve on antimicrobial resistance without IPC. So my action point to the various institutions, starting with all of us here, there's an aspect I learned from my colleague, the head of nursing from Valley Hospital, Madam Beth. And she always tells us to be intentional on what we are doing. And as Valley Hospital, that is the principle that we usually apply, being intentional. And being intentional starts with you. We have been talking about antimicrobial awareness from morning until now, it's past 5. But are you intentional about it? It starts with you. It will not start with institutions. It will not start with any other person. It won't start with the lawmakers. It will start with you. How does it start with you? Start with your grooming. How do you dress up? How do you take care of yourself? When you come to Valley Hospital, and I invite you to come one day, not because you're sick, you can even pay a visit. You'll find different type of staff. And when you look at how those staff are, you realize that these are people who are intentional in what they are doing. For the clinical people who are handling patients, you'll not find them with long nails and stick-ons and all those things that ladies wear. I'm not against ladies, but I'm talking about being intentional. You will never find anyone who handles a patient with colored nails, and that's where the fight starts, being intentional. All of us went for the lunch, where we were taking lunch at the cafeteria, and I went to wash my hands, hand hygiene. I'm not criticizing the facility, but this is a call to the students from this facility and also whoever is here from this institution. That is where we can start. We cannot fight AMR, and yet we have not started from the grassroots. So we are starting from those hand washing sinks. We were with Mr. I think Bogwa, the chief. There was someone like that. We were trying to open the taps, open. We were trying to, to just do the proper hand hygiene, but we were not. That's where it all starts. So being intentional from where we are. If some of us here from this symposium today will take it up and go to the management of this institution example with the photos of those hand washing points and tells them that from AMR Awareness Symposium, we start by improving infection prevention. So that's where it starts. I would request that part of the action point should be we started. For the research, I do a lot of research, and I would request us that let us join these institutions like the IPNET, Infection Prevention Network Kenya. It's an institution where we meet every year and we present our researches, what we've been doing. So if we don't do a research, if we don't do an audit, we cannot improve, and that's what has helped us in Valley Hospital. That's why Valley Hospital, maybe within Nakuru, it's standing out, because we are guided by audits. We have to sit down and think about a certain case. Pick one from the lab. When the cultures are out, pick one. Then decide, sit down, do an audit, and then after we realize that some antibiotics were administered, were prescribed, now we go one by one, talking to the doctors. So I request and I encourage the people who are here, researchers, the students, and everyone. Let us do audit. You can decide to audit. If I decide to audit this room just now, by the way, if that's what we came here to do, I have a whole report of this room. If these seats, which are very nice, if they are in a clinical setup, they could be wrong, all of them, because of the type of material. So it's about thinking outside the box, in quote. That's where all this starts. So we can start somewhere. The last thing is about training. It has been mentioned by colleagues here. Training is very important. You can't tell someone to do what they don't know. So let us embrace training from grassroots, from the institutions. IPC should be the topic for everyone. So IPC will go even to the food that we are taking. So training is very important. Thank you so much.
Thank you very much, a representative from Valley Hospital. Of course, we discussed about Valley Hospital as we're going for lunch. Kind of a center of excellence in Nakuru, as to AMR, and quite a lot. Being an auditor makes someone kind of an investigator, and we take kindly the remarks you've made about our hand washing devices in the cafeteria it's going to be taken for action, and I'm sure my colleague, Dr. Tonui, has noted it. At times when you live in a grass-touched house, you forget that it rains at a certain corner because you're used with it. So thank you very much. Very briefly, yes.
Very
yes.
briefly, because my colleague, yes, just like someone said, he also needs an hour.
Yes, yes, yes.
But my name is Dr. Wendy, and pharmacist. I chair the MS committee at Valley, and for me, one take-home point, or what I picked from here, is about collaboration. The panel that we had just before we went for lunch, representation from human health, animal health, agriculture, environment, and our students. I think that this is something that should not end in settings like this, where we just come once a year. I think there was a student who mentioned, and she really challenged us, and in particular, Dr. Lydia mentioning in the 𝐕𝑨𝑖𝑐, and when it comes to involvement of students, it only comes up once a year. And so I think it's a wake-up call to all of us that we don't have to come to fora like this once a year to talk about antimicrobial resistance, and then we wait another year and it cycles all like we just do it once a year and that's it. I think the partnership and collaboration that we have seen from today is something that we ought to carry on more regularly, more frequently. We can learn from each other more frequently. I think even from what Boniface is just mentioning about audits and all these things, I don't think that we will have to wait 365 days to do such things. And also, I think I want to request that when such fora are being convened, that we do not forget the private setups. I know most of us here, if we are likely to fall sick, or if our family members fall sick, a good percentage of us will end up in the private facilities. But in most cases, when some of these fora are being convened, there is very little representation, and this is what I would to call upon, that this collaboration should not just be one-off events, but rather it should be continuous engagement, because we serve a whole community, and all of us here are, we end up in these facilities. So collaboration, I think, for me, stands out really hard from these conversations. And I was especially very glad when one of our youth really challenged us. I think the voices of tomorrow, we need to really think about how to involve our youth, involve the private sectors, the public sectors. And also, lastly, I think it came out when someone asked about the tomatoes, when one noted that the tomatoes that are being used for home consumption and those being sold, what did you do? And the response about awareness and cautioning, I think one thing that has made us achieve part of the things that we've achieved at Valley is about measurement. Because if you say you're going to talk to someone, and I think we're usually challenged, in most cases, and say, I'm going to talk to these people to know about antimicrobial stewardship. There is no measurement there. How then are you going to tell us that you have achieved whatever you've achieved? If we talk to the farmers there and caution them, what is there to show that you actually cautioned those farmers? What is it that you can show us to know that they were cautioned, they changed from practice A to practice B? I think this is something that we ought to challenge ourselves. Let us not just say, I talked or I cautioned. I think there needs to be a way to measure and know that I talked to this person, and this is what I probably, this is the score that I can tell you that this is how they have changed. So we have to always measure. Thank you very much.
Thank you, Dr. Wilma. it's quite informative what you've talked about. Two perspectives, collaboration and objective measurements of outcomes relating to AMR. We really appreciate that, and I'm sure we're going to work a little bit more. The collaboration perspective that I'm seeing here is quite very encouraging. I'm seeing the local government in place. I'm seeing the county government in place. I'm seeing local farmers working with us. I'm seeing academia collaborating in research and action-oriented practices to try and reduce the risk of worsening AMR. But at the core of this, we have IPC, which is kind of a low-lying fruit that we can be able to deal with. So ladies and gentlemen, I know this is a meeting, a symposium that could actually run for 2 days, and we couldn't stop because, as you see, Victor talking, Dr. Lydia talking, the team from Valley speaking, academia from this side. Ladies and gentlemen, this is a story that cannot end. And as it was said by one of the youths, actually 2 of them, they need to be at the lead of this, not going for the walks alone, because the walks is just public show. The heart of the action is in what we do to prevent the disease. I mean, the effects of AMR. So ladies and gentlemen, at this point, I want us to come to the close of this. I'm requesting Lydia on behalf of the county to make one statement briefly. And thereafter, we shall pass it on to Tonui, who is going to give the vote of thanks. Ladies and gentlemen, it was a pleasure standing here and facilitating this session. God bless you very much.
Good evening, ladies and gentlemen. All protocols observed. It's been a long day, but it's been a successful day. I hope it's been impactful. I'm sure some of us walked into this room today not knowing what AMR is. Perhaps you were sent here on behalf of someone, and on your way you are wondering, Sasa, why am I here? What is this AMR? So you quickly go online to just check and be in spirit with that. Hoping by the time we end, or at this point in time, you have a message that you can carry with you, either at an individual level, that is a personal level, in your career, basically in how you interact. That when you feel a scratch in your throat and you're about to reach, for that azithromycin, you stop yourself because you've become an AMR champion. Yeah? You'd rather take that strepsils and say, let me wait it out. Let me see. Maybe this is a viral infection. Let me drink more water. Let me take some dawa, you know, the ginger concoction. Yeah? And guess what? After 2 or 3 days, that scratch will have disappeared. So definitely, we hope to have created an impact through this interaction. So we hear you. A lot of speakers have mentioned that this should not be a once-in-a-year activity. We hear you. So through the CASIC, which is now in place, we hope to be having quarterly meetings, and in our quarterly meetings, we hope to establish our technical working groups, because it's easier to meet a smaller, impactful group. And the technical working groups will be based around the thematic areas. So when we call upon you to come and give your technical expertise, please join us so that together we can take this message. Somebody has mentioned something about the youth, that it should not only be the ones in universities, living. Yes, we need to also include our primary schools, actually from kindergarten, as Sarah mentioned, that she got to know about HIV through the poems. So if we could come up with rhymes and chimes, a jingle. And just to mention, I don't know if he's in the call, we have a representative from Tanzania, where in Tanzania they have a jingle. And they even have a name for AMR. They call it Uvida. That is usugu wa vimelea dhidi ya dawa. Uvida. So could we have a Kenyan version? Victor, could we come up with a jingle? You know, something that can play, and when it plays, everybody thinks, hiyo ni ile wimbo, tunafaa kumaliza dozi. Tunafaa no sharing our antibiotics. So those are the things that we need to think about moving forward, so that we can bring this message into our households. That, you know, that advert that runs, TB ina tiba. See, we all know TB ina tiba. So ukiona mtu kwa matatu akikohoa vibaya, unamwambia nini? Aende kwa hospitali, si ndio? Apimwe na atapata dawa na atapata kupona. So we need to start thinking around those areas, that now we can remove this message from the boardrooms and we can bring it to our homes. We also need to think about IPC. I thank you so much, Bonfas, for emphasizing the IPC. We need to think about WASH. Are we having sufficient running water in our communities, and what can we do about that? And I'm really excited that our engineer is with us and is passionate about this. So it's late, and we need to now end here. So at this juncture, I really wanted to say thank you very, very much for all of us finding time out of our very busy schedules to sit in this hall and listen to the presentations from 9 in the morning up to this point. Thanks to each and every individual. Thank you so much to Kabarak University, the faculty, team, Dr. Tonui and your team. Thank you so much for the wonderful, wonderful and amazing job. You have very high quality moderators in how the questions were asked and how they were framed, among others. So at this point, let me not become the person delivering the vote of thanks, but on behalf of the Nakuru County, we are sincerely thankful for making this happen. And we hope that even moving forward, we are going to have more and more. Last year, we were here only with the students. We had a small activity with the Heroes Club. A year later, we are here doing an AMR symposium that is not just national, but we also have listeners internationally. So I'm curious to see what next year is going to bring. Thank you very much, and have a good evening. Karibu, Dr. Tonui. This is Dr. Tonui, the man behind all this. Obama up.
So, good evening. We can wave. I think we have some sugar in our system now. Thank you very much. I think we are coming towards the end of our symposium. It's been really amazing. When we started the planning, we did not know who will be here. But I would like to say that Jesus said, if you have faith as small as a what? A mustard seed, eh? Yeah, I wish I knew the dimensions of a mustard seed. Maybe the engineer could tell us. But what we are saying is that we need to believe and have the passion, and the little that you can do will have great impact. Even as we look to fighting AMR and giving our contributions, let us believe in the efforts that we are making in the various sectors. So for today, I'd like to say thank you to everyone who has made it here. We appreciate that we've even sat up to this time, and I'd say may God bless you so much. So we are doing this collaboratively. I think 𝐿𝐴𝐶 is one of our very passionate students. He's a student in the Department of Clinical Medicine, and he will be able to read or recognize the contributions or institutions and individuals who made this symposium successful. So for me is to say asante sana, may God bless you. Let us look at another more impactful symposium even in the coming year. Thank you very much.
Thank you so much, Dr. It's really a humble privilege for me to be found in such a conference, such a symposium at such a time. I am Emmanuel Shikuku, doing clinical medicine, and currently a student leader serving as the director in charge of health, Kabarak University. So straight to the vote of thanks, I would like to thank the Kabarak University for the support they have granted unto us, for enabling us for the funds, and the deans. This is involving the two schools, School of Medicine and Health Sciences, and the School of Pharmacy. Then secondly, I'd like to thank the planning committee for the symposium, and a special thanks to Dr. Lydia and Dr. Tunui, the CASIC members, and the county admin. I would also like to thank the university chaplain for blessing us this morning with a word of prayer, and all the faculty persons from various sectors, the focal person, animal health, human health, agriculture, environment, and community representative, the university faculty, and the students, to be specific, the KUSA and the Heroes Club. I would also like to thank the Valley Hospital for the financial support and the in-person attendance, the chief pharmacist and your team. Thank you so much. And all the faculty members present in person and online, the student representative, both okay. Thank you so much, Dr. Tunui. I was thanking all the faculty members who attended in person and online, the student representatives, the senior lecturers and doctors, just to sample but a few, Dr. Ngotho, Dr. Ogaja, and Ongori. I would also like to recognize the students from Egerton University. Thank you so much for making it a purpose to be found in this place. And thank you also, Victor, for the presentation. I would also like to recognize the national government representative represented by the area chief, Madam Susan Soy and Mr. Patrick Mbugwa. The national focal point for AMR, Dr. Tunui, and being the National Antimicrobial Stewardship Committee, and the support personnel from the Dean's Office, that is Gladys, and for supporting the logistics, and our media for facilitating us to interact through the hybrid platform, both online and physical. Our moderators, that is Dr. Moses Mogesi, Dr. Arthur Ngetich, and the county moderators, thank you so much. And just to highlight on the catering team for the meals and the refreshments. I personally am blessed, and I don't want to take it as lightly to attend such a conference, such a symposium, as I've resumed the seats as the director in charge of health. I've had students complaining about being treated and not getting well earlier or soon enough. And luckily enough, the symposium was around, and I thought it could be better if we plan and sensitize the students concerning AMR. It will be good for the university and through them, they also spread to their communities and their families. And last but not least, I'd like to thank the Almighty God for such a blessed day and keeping the atmosphere conducive for all of us. Thank you so much, and have a blessed evening. Allow me to return the microphone to Dr. Tunui. Thank you so much.
Another round of applause for 𝐊𝐶𝐵𝑄. So thank you very much, 𝐊𝐶𝐵𝑄. I believe by the time you complete your studies, then we will have a great speaker in you. Great. So I think we will then head to the close of this meeting. We are grateful that we have come this far, and I'd like to invite our colleague to give us the last prayer for today. Let's give him a round of applause as he joins us. Mr. 𝐵𝑚𝑜, correct.
Thank you so much, Dr. Tanui. How are you? Mko tired, eh? I know it has been a grueling moment since morning, but it is worthy. This has been a wonderful symposium. I wasn't able to attend the whole of it. I was a bit in the morning, and then I've just rushed back. We had exams to give. Maybe before I pray for, I had a question before I left. I was at a concern in terms of patient education. I had a lot said about the education going on in Valley and the county, but I didn't hear something about the patient education in regard to the resistance. Because, you know, today's patient is sometimes several miles ahead of us. You'll find them wanting to know, which drugs are you giving me? Why couldn't you give me this other one? The pharmacists who are around, you know, they walk to the chemist and they ask for specific antibiotics. And sometimes they insist on it. So maybe just as a thought, I was talking to Dr. Tanui and Moses, and I was saying, was there an aspect of patient education? Because that's a key thing, which stretches even to the public. Because this is important, and we must make sure we are not misusing antibiotics. Can we stand up and pray if you don't mind? Heavenly Father, in the name of Jesus, we bow before you to give you praise. We thank you for your goodness, your kindness, and your mercies that are everlasting. Thank you, Father, that in the morning we prayed for this to take off. We have seen your hand, and it is coming to an end. We want to thank you for everyone that has attended. Thank you for every presentation that has been given here, Lord. Thank you for the education that you have received, and even the learning that has taken place. Even as we live, Lord, there are many areas that are still gray, that may need more attention. And even as there are plans to meet quarterly, we pray that you'll make this successful. As we live, we pray that you give us safe journey mercies to various places, those who are traveling, and even those who are staying around. For we pray, believing and trusting in Jesus' name. Amen. Thank you.
So ladies and gentlemen, thank you very much. We thank the colleagues of ours who are online. Thank you for being there. I'm sure it's been quite a learning experience. And now we can live at our own pleasure without any pressure. Thank you.